interpretation, the normal appearance of the brain. I will go through a little more anatomy on this section today. I know you guys have a separate anatomy class, right? Is most of that all computer generated? You're not cutting up people, are you? No. So you're not missing a damn thing. I got news for you. Dissecting a human corpse is disgusting. Okay, I loved anatomy in medical school, and we did it, and it was kind of fun for a week. But then you go home smelling like that formaldehyde, and you can't get it out of anything. And by the end of, you start in September, and everybody's happy, and by the time December comes around, that thing is rank. So you don't want to do that. So have you done neuroanatomy yet? You're in it now? Okay, good. So, I'm sorry? Well, I'll help you out. I'm probably not going to get as detailed as, well, I don't know how detailed you guys get. That's cool. I always thought I would rather teach anatomy than radiology, but because you got to love anatomy to be a radiologist. You just absolutely have to breathe it. So we'll talk about the modalities and the common imaging abnormalities in neuroimaging. Okay, so I think I might have showed you this slide before. You guys don't need to see that. Okay. And the one thing that I will say is just as true for chest imaging as for any other kind of radiology for neuroimaging. When you think you found the abnormality, keep looking. Satisfaction of search error. This is something I have to deal with all the time because I work on the medical director for about a practice of 380 radiologists that read all over the country. And I'm one of the guys that gets to field all the complaints when our radiologists miss things, because we're human beings, we miss things. And the one thing that I find is most common is that someone finds a finding and thinks they're done. And they're done. They're not done. You got to find all the findings. That's called the satisfaction of search error. And so always keep looking until you cannot stand to look anymore. Okay, so let's talk about neuroimaging. So what is it that we are looking at when we talk about neuroimaging? We're talking about skull and brain, and spine, and vasculature. Okay, so what are the techniques we want to use? Well, skull, of course, is the first thing you would think about is the skull X-ray, which actually is an absolutely crappy way to look at the skull compared to CT. But it's cheap and it's easy. Finding skull fractures is not a particularly easy thing on an X-ray. There's a lot of lines and stuff, those sutures that you've probably seen on pictures and whatever. Similarly, for the facial bones and sinuses, CT is a much better way to evaluate those things than plain X-ray, but we still do them. Interestingly, ultrasound is very useful, especially in newborns. Now, I haven't gone into the physics of ultrasound very much, and I will not. But clearly, you would think that bone is not a great window for ultrasound, that it would block all the ultrasound waves, and it actually does, except for when you're a newborn, you got this hole in the top of your skull called the anterior fontanelle, where the skull bones haven't fused yet. You've also got one in the back. And if you're a really good sonographer, you can find a little hole on the side, and you can direct an ultrasound beam through that hole and see the intracranial anatomy of a newborn absolutely beautifully. And we use that all the time to look for early bleeding in the brain of a premature infant, for the most part. Of course, CT and MR are spectacular for the neuraxis, for the brain and the spine, whether without intravenous contrast or with intravenous contrast, and I'll show you some of that stuff. And then, of course, we have some very special ways to look at the blood vessels of the brain, the blood vessels that feed the brain, the carotids and the vertebral arteries, and then the blood vessels in the brain itself. So let's talk about some techniques of radiography, ultrasound, and CT. When we're talking about imaging the spine, we've got some imaging direction that you need to be aware of, including the anteroposterior, the lateral, and the oblique views. When we're imaging the spine with X-ray, sometimes it's helpful to have the patient go into extension or into flexion, and that can give us some information about the stability of the spine. And if any of you have ever had an X-ray of your cervical spine, you may recall someone asking you to open your mouth so that they can do an open mouth odontoid view or an atlantoaxial view of the cervical spine. Already talked about ultrasound a little bit. CT and MR I'll talk about in just on the way down. But when it comes to being definitive about intracranial and spine abnormalities, really CT and MRI is where everything is happening now. We can say some things on X-ray about the spine. We can say some things about the skull. We can't say anything with X-ray about the brain or the spinal cord or the nerve roots or any of that stuff. But with CT or MR, we definitely can. So CT is definitely the procedure of choice for when you're concerned about a fracture, especially of the spine, when you've got a penetrating injury, and because it's in red text, it's extremely important, acute hemorrhage. Acute hemorrhage in the brain. Study number 1, CT, always and forever, okay? That one is very important, which is not to say that MRI is not important. MRI is spectacular for a number of things. MRI isn't spectacular for acute hemorrhage for a number of reasons. The physics of MRI don't work particularly well for acute hemorrhage. MRIs take longer to do. When someone is suspected of having intracranial hemorrhage, time is of the essence. You want to diagnose it, you want to fix it. MRI can take 40 minutes. You know, CT can take 30 seconds. So that's definitely where you want to go. Plain X-rays of the skull, for a number of reasons, very limited. But that doesn't stop us from looking at the anatomy. Okay, I think there are 22 bones in the skull and facial area. So there's a lot of bones that are stitched together, and all these bones have very odd shapes. But generally, we're talking about the frontal bone, right? The parietal bones, which are on the sides for the most part, the occipital bone in the back. And then there are some features that you can see on the lateral view of the skull. There's the sella turcica, which means, anyone know what it means? There you go. I've never been in a Turkish saddle. I don't think I've ever actually seen a Turkish saddle, but I'll bet it looks like that. So, and what's in there? The neurohypophysis, right? Pituitary. So, on a frontal view of the skull, we've obviously got the frontal bone, we've got orbits, nasal bones, which are actually much better seen on a lateral view if you're looking for a nasal bone fracture. The zygomatic arch, and the mandible and the mastoid air cells. I really don't want to spend a lot of time on this stuff. Sinuses, though, are, sinuses are very variable. Like a lot of things in anatomy, they're not all, the way the textbook reads. So the sinuses that we're most concerned about are the frontal, the maxillary, the ethmoid air cells, which sit right behind the nose, and then the sphenoid sinus, which you don't really see very well on the frontal view, but you'll see on the lateral view. We're looking for things like fluid in the sinuses, thickening of the mucoperiosteum, and of course, in trauma, you're looking for fractures, etc. So it's a little different view, the Waters view, where the beam is angulated. The beam is angulated up, I can't even remember. We do this so infrequently anymore. But it's a better look at the ethmoid air cells and frontal sinuses, probably a more complete look at the maxillary sinuses. On the lateral, here's that sphenoid sinus in the sphenoid bone, right beneath the sella turcica. Again, some of these are variably aerated, and like a lot of things in radiology, sometimes harder to see what isn't there. If the sinus is filled with fluid, you might just forget that it was there and call it normal, but you got to remember that there should be something air-filled there. So we all understand, right? We understand why the air is dark. We're all good with that, right? Why the fillings are metallic, right? Okay. I said something in the last lecture that I want to clarify. One of your colleagues was astute enough to bring it to my attention. I said that ionizing radiation requires a prescription, a doctor's order. And then I said, screening mammography does not require a doctor's order, which is true. Screening mammography is the only exception to the concept of radiation requiring a physician order, okay? And the reason is because the disease is prevalent, we want people to be screened, and the radiation risk for a screening mammogram, even 20 years worth of screening mammograms, is infinitesimal compared to the risk of developing a breast cancer. When the disease prevalence is 1 in 8, 1 in 10, you stand a much better chance of having an undiagnosed breast cancer than you do of having a breast cancer caused by radiation. So that's why you don't need a doctor's order for screening mammography, but you do for everything else. Okay, now compare that view of the face to that view of the face. A little more detail going on here, okay? Remember that CT scans create slices. So as if you were in a bologna slicer, okay, you would get axial images of your brain. Axial, that means this way, right? This is coronal. This is coronal. Did you learn this in your anatomy, all this stuff? Okay, good. So I don't want to spend too much time on it. Axial and coronal views of the, in this case, the lower face and upper cervical spine. And here's a coronal image pretty much through the maxillary sinuses, through the orbits, ethmoid air cells. There's a little bit of fluid layering in the right maxillary sinus. Remember also the convention is that you are always looking at images, axial images, as if you were standing at the foot of the bed and looking at the patient. So if I'm standing at the foot of the bed and I'm looking at that patient, then that is the patient's left, that is the patient's right. That is anterior, that is posterior. If I'm standing at the foot of the bed and I'm looking at the patient, that's the patient's left, that's the patient's right. Superior and inferior, okay? That's convention. You're never gonna see a CT scan where the patient's right is over here. Okay, if you do, somebody made a mistake. This is the next talk I have to clean up, okay, because I didn't put these slides together. Not all of them. I didn't really, so we talked about this brain ultrasound business, about through the open fontanelles. I'm sorry about this, I'm kind of jumping around. Remember that there's a higher risk of intracranial bleeding in the premature newborn, okay? So less than 32 weeks, very high risk. That choroid plexus in the ventricles is very, very friable. And the possibility of developing intracranial hemorrhage is very high. And that's what we're looking for. The good thing about ultrasound of the neonatal brain is that you can do it every day. In fact, you do it every day. In a neonatal ICU, we would scan these kids every single day, just until they were old enough to get out or well enough to get out. So you're not hurting anybody by doing the scan. These are two sagittal images. Sagittal images. So the baby's face is over here, back of the head is over here, face is over here, back of the head is over here. So this is a sagittal view through a normal ventricle. The ventricle has normal CSF in it. So as I said, just like in the breast cyst, where that cyst was black, the black fluid, here the fluid in the ventricle is black. And take my word for it, this is normal. But notice how this is much different. There's this thick of white stuff here. This is actually acute hemorrhage in the ventricle. So, and the ventricle is dilated compared to there where it's kind of slit-like. So what do I want you to know about neonatal ultrasound is that it's cheap, it's easy. You're looking for hemorrhage in the infant brain, and that the infants that you're scanning tend to be premature because they're at higher risk.
So the black area on the mouth is the ventricle?
Black area is the fluid, the CSF in the ventricle. That's correct. And this little white area here is there's something called choroid plexus in the ventricle, that's normal, okay? It's normal to have a little bit, but here, the ventricle is this whole thing, and there's kind of like a blood fluid layer. Okay, so here's normal fluid, and then here's blood layering in the ventricle. And so the ventricle is way too dilated. Here, the ventricle is only that. It's only that wide. Here, it's that wide. Okay, maybe not the greatest example. Here, you can see this is normal, and this is a coronal view now. Okay, so this is as if you were looking directly at the face. Okay, the patient's right is over here, the left is over there, and these little slits are the normal CSF in the ventricles. They're tiny, but again, same projection. Now you've got these ventricles that are all dilated here. There might be some old hemorrhage. Once you get hemorrhage in a ventricle, then the normal resorption mechanism doesn't work as well. And so what happens is, because the blood actually keeps the CSF from being resorbed, so even though the blood may start to disappear, the CSF keeps being produced and it doesn't get resorbed, so the ventricles get dilated. You put a shunt in these kids. Sir.
On the coronal view, that's normal.
Yep.
Where's the probe placed? Is it right in the anterior
Yep.
canal?
Yep, it's just turned. So that, so the beam may be doing this, in which case I get a sagittal image. And I turn the probe and it does this and I get a coronal image. Okay, so let's talk about CT. The rest of, I think most of the rest of this is CT and MR. So I said that this CT scan is like a bologna slicer. And so we take multiple slices. And a head CT, on an average head CT, will take about 18 slices. The earliest head CTs, the first commercially available head CT scanners were only head CTs. You could only get a human head in it, couldn't get the whole body in it. And the slice thicknesses were 10 or 20 millimeters. Today we do slice thicknesses of 3 millimeters, 1 millimeter, even smaller. And a single slice took 10 minutes of computing power to create. Now we can do a whole head CT in 5 seconds. So just an idea of the scale of the computing and the technology that's come. So we make these slices, 30 to 60 slices of an entire brain, probably a little lower than that, but that's okay. And we can choose to either do the scan without injecting any IV contrast, or we can give IV contrast and light up certain tissues inside the brain and the vessels. Most head CTs are done without IV contrast. There are very few reasons to use IV contrast anymore now that we have MRI, which is much more sensitive for certain things, but not blood, right? So which is better? As I said, CT is faster, and it is the preferred method for emergency situations. CT is much better to evaluate the bones and for acute blood in the brain or around the brain. And CT is the method of choice to evaluate head trauma. So just about anybody who comes into the ER with headache, MVA, head trauma, fell down the stairs, head trauma, just about anything related to the brain is going to get a head CT. On a given night when I was reading in my teleradiology practice, and I would work from 9 p.m. to 7 a.m., something like that. I would read maybe 140 studies total in that time. 70 of them were head CTs. I mean, just all night long, every ER in the United States is cranking out head CTs. So how do we orient ourselves? What are we doing? This is what's called a scout film for CT. It kind of tells you where the slices are that you're looking at. So every slice has a number, and when you look at slice number 2, you know it was taken there. Okay. The slices are generally oriented toward this line through the base of the skull. Most head CTs, the CT techs know to orient these the same way. It's not always done because patients are kind of moved. Sometimes they're moving, sometimes they're impossible to get on the scanner properly. But we have a general idea of the plane of section. So it's not like we're doing it this way, right? We're always doing it this way, which is predominantly in the axial plane. Don't need to get too crazy about the anatomy, but since I know you guys are doing it, remember, of course, that the brain and brain stem are made up of, two cerebral hemispheres. The cerebral hemispheres are made up of the temporal lobes, parietal lobes, frontal lobes, and occipital lobes. Is there a perfect delineation of the parietal lobe from the temporal lobe? Not necessarily. There is generally a delineation between the frontal lobe and the parietal lobe, which is the central sulcus. Thank you. But on a CT scan, the central sulcus can be hard to find. It's got a couple of landmarks. We're not going to go into it, but on a gross section of the brain, you can almost always find the central sulcus pretty easily. On a CT scan, a lot of times I'm fudging. Is it frontal? Is it parietal? I don't really want to bother. It doesn't matter, right? A lot of times it doesn't matter. And then, of course, there's the very complex ventricular system, which is difficult to wrap your arms around. But actually, this is a nice picture of it. Two lateral ventricles, third ventricle, foramina of Monro, right? Here's fourth, and then we get into the central canal of the spinal cord. So let's start looking at some CT scans. These are axial images. So the patient's right is over here. Here's the right ear. Here's the left ear. Mastoid air cells. And this is a section through the absolute bottom of the brain. So you're getting mostly, you're getting this structure here, which is the most inferior, posterior, which is the cerebellum, right? Problem with looking at CT scans of the brain down here way low is that these bones, which are the base of skull is a little higher, but this is really dense bone, which is where the inner ear lives in there, in the temporal bone. Okay, the petrous portion of the temporal bone, right, causes a lot of artifact in CT scans. Very difficult to be very precise on CT scan. Notice in here, I mean, we know there's also all kinds of very delicate structures in here. There's the brainstem, there's the cranial nerves. Can't really see them very well because there's an artifact of beam hardening. I don't have to go into why, but it's just a difficult area to see because of the very, very dense temporal bones in that location. A little more anteriorly is the base of the temporal lobes. Okay, so cerebellum, base of the temporal lobes. Go up a little higher, a little further up. Now I've got cerebellum, fourth ventricle, midbrain, call it the pons. They're calling it the pons. Okay, it's the pons. Here's the sella turcica, right here, with the pituitary in it. I don't see it very well unless there's a mass. A lot of times the pituitary is just squashed up against the floor of the sella. It's called an empty sella, but it's perfectly normal. It's just a variant. Now a little higher up in the temporal lobes, and now you're getting the floor of the frontal lobe here. We're all good on as we move through? Going higher still. Now, I'm pretty much out of that area where the bone is so super dense. The skull is dense, but it's not causing me any real artifact problems at this point. And now, I'm really loving symmetry. I want everything to be the same from one side to the other. The brain is absolutely symmetric when it's normal. It's as far as imaging is concerned, it is symmetric. You want to see symmetry. If you see symmetry, chances are you're dealing with a perfectly normal brain. Okay, so you can kind of see the folia of the cerebellum here, the central portion of the cerebellum. Now you've got the quadrigeminal plate. There's a cistern here, a CSF space, portion of the third ventricle, And then you've got temporal lobes and frontal lobe. Sylvian fissures, this is where the vessels, remember the middle cerebral artery comes out, runs into the Sylvian fissure on either side. So the thing you want to be able to start to see on these CT scans of the brain is you want to identify CSF filled spaces and soft tissue. Now, CSF filled spaces can be ventricles, but they can also be cisterns, which are not ventricles, okay? So not everything that is CSF, which is black, by the way, because water density is essentially black on these scans. There's a whole bunch of physics that goes into why that is, and we're not going to talk about it at all. But for our purposes, black on the CT scan is fluid, gray is tissue, white is bone, and then there are certain pathologies that are going to be white, like acute blood and other things. But in a normal CT brain, fluid is black, normal brain tissue is gray, bone is white. Now we go up a little higher. Now we start getting into the frontal horns of the lateral ventricle. Here's the midline again, and there's something called the falx, right? That's the midline divider between the brain, the cerebral hemispheres. There's a anterior falx and a posterior falx. It's the same thing, it just happens to go through. Now you can, if you, it may read a little better on your slides, I'm not sure, but there's some density differences here. There's the internal capsule, there's basal ganglia here, the caudate nucleus, putamen, globus pallidus. On a CT scan that I'm looking at for diagnosis, I can, if it's a young patient, I can tell all of those structures. I can identify all of them. Older patients tend to have lost significant brain mass just as a function of getting old. Their brain starts to shrink. It starts to look like a walnut. It's not particularly pretty, and you start to lose some of that fine anatomic detail. A little higher still. Now you're into the bodies of the lateral ventricles. There's the midline falx. Very important for me, that midline falx, because if I think that there's something pushing on one side or the other, I'll take my electronic cursor and I'll draw a line from there to there, which is the middle of the skull on either side. I'll draw a line. If my falx falls right on that line, then I know nothing's pushing it one way or the other. If my falx is pushed over, if it's deviated, then I know I need to look for something that might be pushing it. Brain is the brain case, the skull. It's a closed space. There's nowhere for anything to go. So if there's a mass, it's going to push something away. You're going to see it. You may not necessarily see the mass. You're going to see the effect of the mass, and that's something that you got to look for. That's why symmetry is so crucial in the brain CTs. You always want to make sure that things look the same on one side and the other. All right, let's talk a little bit about the use of IV contrast. IV contrast is basically a clear, colorless, odorless liquid, but that liquid has a high iodine content in it. And if you inject it intravenously, what you're doing is you are increasing in the blood vessels, or whatever the blood vessels are feeding, you are increasing the amount of iodine that gets into that space, and iodine is very radiodense. So those X-ray photons that are coming from the CT scanner tube are encountering those iodine atoms in your bloodstream, and it's causing your blood to look more and more dense by the CT scan. So that's why we use IV contrast. It's the same reason why someone drinks barium to have an upper GI. The barium atoms in the barium are very radiodense, and when I use fluoroscopy, I see white where the barium is. If you just drank water, I wouldn't see anything, because water is, your whole body is essentially made of water. So it's no different. So we use this IV contrast to light up blood vessels and to light up. Some tissues are more vascular than others, and we'll see them better. Yes, you can be allergic to iodine contrast agent. You cannot be allergic to iodine. If your patient tells you they're allergic to iodine, they're not. Okay? You have iodine in your bloodstream, you have iodine in your thyroid. You can't be allergic to iodine. If your patient tells you they're allergic to shellfish, they might be allergic to some proteins in the shellfish. They're not allergic to the iodine in the shellfish. And it's really not a reason why you have to worry too much about it. Won't go into it any more than that, except that you will have patients that say, I'm allergic to iodine, or I'm allergic to shellfish. Just tell the doc you're working with, and that. Just tell your radiologist. I mean, you tell me that, and I'm like, I don't care, you're not. Okay? But somebody who's had a reaction to iodine-based contrast agent may be allergic to certain proteins in the contrast agent, but they're not allergic to the iodine. It's good to know, though. You want to know it. Anyway, so let's look at these two CT scans. They're done, same patient, same level, the same level of the brain is being scanned. And you can see that on this one, you've got your gray, and you've got your black, and you've got your bone. And on this one, you've got your black, and your gray, and your bone, but then you've got this, and these things here, and kind of down here, there's some whiteness that isn't over there, okay? And this is the patient that got contrast, IV contrast, intravenous iodine contrast, so that the blood that is in these blood vessels, the middle cerebral arteries, has iodine in it and is now denser than the blood was before we gave them the iodine. And it just happens that in the brain, the meninges also love iodine contrast, and you'll see the meninges better. This is something called the tentorium cerebelli. It sits above the cerebellum, separates the posterior fossa from the supratentorial region. That particular structure loves iodine, and it brightens up. So notice how the falx is brighter here than it is here. That's the meninges, the dura and the pia, etc. Okay, so I mean, we kind of ran through this. I don't know that we necessarily need to run through it again. Well, again, you can see this kind of streakiness here. See the streakiness? This is the artifact of the petrous portions of the temporal bones. This is the petrous portion of the temporal bone. It's probably the most or second most dense bone in the body. I don't think enamel really qualifies as bone, but that's really dense right there, and it's just playing havoc with the physics of the scan. There's the temporal horns of the lateral ventricles, frontal lobes, fourth ventricle, pons, cerebellum. A little higher up again. I mean, we kind of did all this. Anyone have any brain anatomy questions that either from this or from your anatomy lecture that might be unclear? I'm sure your anatomy references are much better than these, so I wouldn't expect you to have too many questions, but you probably got it all figured out. Okay, now let's talk about some things that are directly related to imaging the brain. As I've noted several times, CT is the method of choice to identify intracranial hemorrhage. And anybody who comes to the ER with head trauma, it seems that we must exclude intracranial hemorrhage, whether or not they actually even have the remotest chance of having it. Because you tell an ER doc that you hit your head, and he's going to get a head CT. Why? Because if he misses the intracranial hemorrhage, even though the likelihood of you having it is almost zero, he's going to get sued. And unfortunately, that's just the way it is. So what we're looking for in the brain when we're looking for intracranial hemorrhage will depend on how fresh or old the hemorrhage is. Obviously, if someone gets in an MVA and goes to the ER within an hour, and is suspected of having intracranial hemorrhage, it's going to be pretty fresh. For reasons that are absolutely unnecessary for you to bother yourselves with, fresh hemorrhage in the brain looks white on a CT scan, okay? And as the hemorrhage ages. And by ages, I mean over several days to several weeks, that whiteness will get grayer and grayer and grayer, and will actually ultimately will disappear. And what will be left in its wake, if it's hemorrhage inside the parenchyma of the brain, will be an area of encephalomalacia where the brain basically died, okay, and is being filled up by CSF because nature abhors a vacuum, and wherever something is inside that skull and gets slowly resorbed, something is going to fill the space. Two kinds of acute intracranial hemorrhage. Actually, there are four kinds of intracranial hemorrhage, 5 kinds of intracranial hemorrhage. Sorry, it's been a long day. But 2 of the ones that I want you to specifically think about are the the epidural hemorrhage and the subdural hemorrhage, because these are the 2 that are most commonly associated with head trauma. The epidural hemorrhage is an arterial bleed and can cause rapid accumulation of blood in the epidural space. And when you get a rapid accumulation of arterial blood, you're going to push that brain away, and potentially cause the brain to what we call herniate across the falx onto the other side or down into the spinal column. Okay, both of these things are not anything you want ever to happen to you because it's pretty much fatal. So we want to be able to identify the epidural hemorrhage. The subdural hemorrhage is actually a venous hemorrhage, so it's not under so much pressure, but it happens to spread a lot faster. Now it'll spread faster, but it'll also accumulate, maybe slower, but it will also push the brain away, and will also cause herniation, either subfalcine herniation below the falx or foraminal herniation down, and also not a good thing to have. The subarachnoid hemorrhage is hemorrhage that, yes, it can be associated with head trauma, but tends to be more associated with ruptured intracranial aneurysms. Intraparenchymal hemorrhage can be associated with head trauma, but tends to be more related to ruptured aneurysms that rupture into the brain parenchyma. And then the intraventricular hemorrhage also tends to be aneurysmal related hemorrhage that ruptures into the ventricle. Because if you think about it, if you've got a blood vessel that's under arterial pressure at the base of your brain and it's got an aneurysm in it, and the aneurysm blows, it's going to direct that blood like a fire hydrant right into the brain parenchyma, right into the ventricle. It's just like you took a hose under pressure and just was hosing away some dirt or something. It would just go right through it. Okay. This is it's an older CT scan, but it nicely demonstrates a couple of important findings. On this scan, there is both subdural hemorrhage and epidural hemorrhage. Subdural hemorrhages tend to be elongated and occupy a large portion of one side of the brain. I should qualify that as I want to be cautious here because understand that these are not hemorrhages in the brain itself. This is hemorrhage outside the brain. Radiologists will call this the extraaxial space. Radiologists will refer to the intraaxial portion of the brain as the brain parenchyma and ventricles, and extraaxial brain as the epidural space and the subdural space. So this is a hemorrhage which has got a lot of whiteness in it. It's also got some dark stuff in it. This one may not be super acute. It's maybe, several days old where it's starting to resorb. But this one, and I'll show you a better example of it, and I wish I could point to it better, where it says EDH, that's the extradural hemorrhage. The extradural hemorrhage is classically described as lentiform, or the shape of a lens. And it tends to be bordered by the sutures of the brain. And I'll show you a cartoon a little bit here about why that is. But the epidural hemorrhage because that's arterial blood being pumped into a very small space, it gets big fast, and it will push the brain away. Epidural hemorrhages tend to be associated with skull fractures. You will usually find a skull fracture right there where the epidural hemorrhage is. Subdural hemorrhages are not associated with skull fractures. Keep that one in your mind. Remember that. So there are a couple of other findings on this. So this patient has all this blood outside of the brain on the right side. But notice what's happening. Notice that falx right here is being pushed to the left. So there's mass effect. There's right to left midline shift. Notice that I see the left lateral ventricle here, but I don't see the right very well. Actually, this is the right lateral ventricle with calcified choroid plexus in it, but it's also being pushed. It's being effaced. And not only is it being pushed, but it's being narrowed, and the opposite ventricle is enlarged. What's happening is actually that the brain is sliding under the falx because of the mass effect from this hemorrhage. The brain is sliding under the falx. It's pushing, it's squashing this ventricle on this side, and it's pinching off the ventricle on the opposite side. So this ventricle is starting to blow up because it can't resorb its CSF. And it's an ominous sign of herniation of the brain. And you would want to get this patient to the OR as soon as possible to evacuate this hemorrhage and let everything come back. Sir.
Would there also be effect on the other ventricle from CSF pressure coming across with the one that's being compressed?
I think I understand your questions, because this one's being pushed and thinned. Is it pushing the CSF into the other one? Yeah, it's possible, but it's not really quite the way CSF dynamics work. It's certainly possible. The reason why this ventricle is blowing up is because as the mass effect comes under the falx, it basically is pinching off any chance for CSF to flow out of it. Okay, but the lining of the ventricle is still making CSF. Okay, so it's making more and more, but it has nowhere to go. Okay, so it's like it's being pinched. I don't know if that answers your question, but I understand. I think I understand your question. So, this is a crappy older scan, but notice here on the unaffected side, we have these lines of dark black. That's CSF in normal sulci. The brain looks like a walnut, right? So it's got the gyri, which is the brain parenchyma, and the sulci, like the hills and the valleys. So this is normal CSF in the valleys on the unaffected side. But on this side, you don't see that because the brain may be swollen because of the trauma, but also because this is pushing. All the valleys are getting squashed, and there's no valleys left on this side. Notice this is the line that I said that I will draw on scans, because what I'll do is I'll draw this line, and then I'll measure from here to here, and I'll be able to tell them exactly how many millimeters of midline shift there is, right? Because this should be in the middle, and if it's pushed over there, and I can say to the neurosurgeon at 2 o'clock in the morning, your patient has 6 millimeters of right to left midline shift. Now, if it was 1 or 2 millimeters, he may say, all right, I'll watch it. I won't do anything. I'll wait, scan him again in the morning, do a neuro checks and do them. But if it's too much, he's got to go in. He's got to put a burr hole in the skull. He's got to suck all that blood out so that everything can move back.
Is this a significant epidural?
Yeah. Yeah.
The epidural doesn't look big to me.
Oh, I'm sorry, the epidural. At this moment, no. Correct. Right now, the action is on this subdural side. Okay, I beg your pardon. You're right.
No problem.
I think I'll show you a more significant one. Oh yeah, that one's a little better. So here's a big subdural. Look how the falx is being bowed. Everything's being pushed. The atrium of the left lateral ventricle is really dilated. I don't see the right lateral ventricle at all. Right? So this is obviously not good. Now, here's the epidural. This is the lentiform shape of the epidural. Looks like a lens. Notice how it stops. It stops right here, here and here. This one doesn't stop. It just goes almost entirely. It yes, sort of stops here. The reason why this stops is because, and I think I can show you in a cartoon, but I want to try to describe it to you. You've heard of the dura mater. What does it mean in Latin?
Hard.
Tough mother. It's a tough mother, the dura mater. Okay? The dura mater is very closely applied to the skull, to the inner lining, the inner table of the skull. And the only things that are in there are branches of the middle meningeal artery. And so if you fracture your skull and you ding one of those branches of the middle meningeal artery, but the tough mother is intact, you haven't damaged the tough mother. Now you've got arterial blood pumping between the inner table of the skull and the tough mother. Well, the tough mother also happens to be tethered up into the skull at all the sutures. So you've got you've got this sagittal suture and you've got sutures on either side. So when the arterial blood is pumping in between the skull and the tough mother will give way, but it's attached to the sutures of the skull. And so it's not going to give way where it's attached to the sutures. So there's a suture here, and the tough mother is stuck up in there. And there's a suture here, and the tough mother is stuck up in there. But it's bleeding in here because the fracture is here. And the arterial blood is enough, it's under arterial pressure. It's strong enough to push the tough mother away. But it's not strong enough to actually tear it out of the skull, which is where it's attached. So this thing gets bigger and bigger and bigger, and is obviously a danger. I mean, they're both very bad to have, sir.
Would a hemorrhage between the two layers of the dura be considered an epidural?
No, in fact, that's what a subdural is. That's what we're going to go right here. So here's the skull. The dura is here. Sorry, the dura is here. Okay? So you've got arteries and veins running in here. What happens in the subdural is that I told you it's a venous hemorrhage. So there are bridging veins that run between outside the dura and the brain itself. Okay? So what happens is if the brain is, if there's an MVA, and the brain is moving at 40 miles an hour, and then the brain is moving at 0 miles an hour, all of a sudden, the brain will actually move in your skull, right? It'll actually move a little bit and then recoil. And when it does that, it'll tear those bridging veins. And when it tears the bridging veins, here, you get blood accumulating in the subdural space, okay? Unlike the arterial blood, so here's the hemorrhage in the subdural space, which is this one here. This one. Sorry. This one. Subdural. Sorry. So here's the dura, and the blood is accumulating here, pushing the brain away. The dura is this red line here, right? That's the dura. On this side, here's the dura here. Notice that this is epidural, outside the dura. This is subdural, below the dura. Sir?
So are there then two kinds of subdural then, being between the two dura and being between the dura and the arachnoid?
Well, I think there's one kind of subdural hematoma. Okay, that's below the dura. There is a subarachnoid hemorrhage, which is actually in this space here. Okay, the pia doesn't come into play here because the pia is like one cell thick, right? I understand it gets a little confusing, but for the purposes of our discussion today, I want you to understand that subdural means venous, epidural means arterial, epidural usually means fracture, okay? And, but both can cause mass effect, both can cause midline shift, And the reason why the epidural is a little more dangerous is because it accumulates much faster. The brain doesn't have enough time or chance to adapt to the rapid change in pressure being pushed on it. And because the epidural is confined to a smaller space and it's rapidly enlarging, it's going to push that brain faster. So that's why, those are the differences between epidural and subdural.
On the subdural diagram, it says inner membrane and outer membrane on the upper right, and then just what?
Yeah, I don't even know what that means. Well, here's the dura. I mean, the dura is red. Inner membrane and outer membrane, I'm not even sure what that means. Can we ignore that? Let's ignore that. A little confusing, but okay. Remember what I said about finishing before 5? Forget that. Okay, so subdural, epidural, make sure you get that. Okay, I'm sure it's discussed nicely in the textbook as well. But I think I've gotten everything that I want to say about that through to you. Intraventricular hemorrhage, again, remember what I said. Acute hemorrhage on CT is white. And here's a patient basically that had an acute parenchymal hemorrhage right here that basically spit blood into the ventricle, okay, right through the interface between the ventricle and the parenchyma. This is a common place for hemorrhagic strokes in the basal ganglia, right alongside the ventricles. There are these small vessels, the lenticulostriate arteries. They tend to break down. If you get high blood pressure, these lenticulostriates are very fragile, and if the pressure gets high enough, boom, one of them goes. It's under arterial pressure, and it's just going to bleed into the parenchyma and potentially bleed into the ventricle itself. So, I mean, you can tell intraventricular hemorrhage because it largely takes the shape of the ventricle, or it may layer in a ventricle here. Sometimes you'll see the CSF is black, and then down here there's just a white, there's a line, and then it's all white. So the hemorrhage is basically the patient's laying supine, and the hemorrhage is just layering back into the CSF space. Yeah, there you go. This was probably actually the same patient, just a different level. Here's the intraparenchymal hemorrhage in the basal ganglia. It's a white blob in the middle of gray, surrounded by gray. So that's how you know it's in the parenchyma. And then here's the white stuff layering in the bottom of the atrium of the right lateral ventricle.
Does that have some kind of weird name, like a meniscus sign or anything weird?
Yeah, I mean, it will often look like a meniscus. I mean, yeah, I mean.
But it's not called that.
I don't think so. I mean, that might come to me later, but blood is great because it's got cellular elements and plasma, and whenever it mixes with stuff it shouldn't be mixing with, it'll usually like layer out. If you took a tube of blood and just set it down, you'd get a plasma layer and a cell layer. Well, if you took an X-ray of that, the cell layer would be dense, the plasma layer would be not dense. Right? It's the same thing. Okay. Now, just to confuse you a little more on these spaces, we talked about epidural, we talked about subdural, and now there's subarachnoid. So the thing that you need to know about the subarachnoid space is that it basically bathes the brain in CSF. So subarachnoid space is everywhere. It's everywhere, and it's all interconnected. And the CSF can get blood in, the subarachnoid space can get blood in it, and it will look white, but it will also outline, the whiteness will outline all of those spaces and interstices where the CSF is bathing the brain parenchyma itself, the surface of the brain. So this is right on the surface of the brain and all the little nooks and crannies and those cisterns that I was talking about. So here we have, I want you to look at these areas here and here. you guys, you're studying anatomy, you know about the Sylvian fissures. Sylvian fissures are where the middle cerebral arteries are basically running out from the carotids. And the Sylvian fissures are CSF spaces. They're in the subarachnoid space. That is subarachnoid space. And if you get hemorrhage in the subarachnoid space, your Sylvian fissures, which should look black because they should have normal CSF in them, now look white, like this and this. The quadrigeminal plate cistern, sorry, the perimesencephalic cistern here is white, where it should be black. This is the perimesencephalic cistern, don't worry about me. Perimesencephalic cistern is white. Supratentorial area, white, should be black, should be just normal CSF in there, but it's all white because it's all blood. So if I were to show you that picture and give you 5 choices, the choice you would want to pick is subarachnoid hemorrhage. What this is basically showing you is the cartoon of the aneurysm in the artery that runs in the subarachnoid space. And when that aneurysm explodes and bleeds into this space, now you get the neurologic emergency of subarachnoid hemorrhage, hemorrhage in the subarachnoid space. And we can call it a stroke, but what it really is, I mean, it's usually due to either some blood vessel problem. You can get subarachnoid hemorrhage in trauma if a small vein in the subarachnoid space breaks because of the shaking of the brain. It's not particularly common in trauma, but it does happen. But it's the first thing you would think about in subarachnoid hemorrhage. Patient has the worst headache of their life. You do a CT scan. They have that appearance. That's an aneurysm. It's a ruptured aneurysm. You got to find it. Now, most of the time, if it's a ruptured aneurysm and if it's a left middle cerebral artery aneurysm, then most of the abnormality is going to be on the left. But you can, like I said, this subarachnoid space is continuous across the entire brain. Over time, it'll all be abnormal. But on the acute phase, you'll usually be able to pinpoint approximately where the aneurysm is.
Would this be a time when you're thinking to give a diaphragm CAT scan?
Actually, good question. And the answer is no. If you give contrast routinely on patients who you suspect have an intracranial hemorrhage of any kind, especially subarachnoid hemorrhage, you could mask subtle hemorrhage because the contrast is bright and the CSF, you want to find the bright CSF. And if it's only a little bit, and sometimes these are very subtle, you will miss it. So you don't want to give contrast if you suspect intracranial hemorrhage.
So is this a venous or an arterial?
These are usually arterial. Yeah, the aneurysm bleeds are almost all, they're all arterial by definition. It's just another example of a little more subtle subarachnoid hemorrhage. So there's a little bit here, there's a little bit here, right? But note, I mean, the whole CSF, the whole subarachnoid space is not involved. And that's a lot. That's a little. Okay, we good? Yeah. So let's talk about stroke. Now, the word stroke to the layperson can mean just about anything. It can mean hemorrhage in the brain, it can mean embolism, thrombus. We need to be a little more particular about how we describe stroke and what we're talking about. Stroke can be embolic, where something flies off out of the heart, off a carotid artery, flies up into a small vessel, arterial feeder of a portion of the brain, and sticks there and prevents the brain distal to it from getting significant blood and starting to die. Okay, so someone who has an acute hemiplegia or droop, facial droop, something like that, suspecting an embolic stroke. stroke can be thrombotic, which means nothing really flew up into the arterial tree, but the arterial tree, for whatever reason, is thrombosing. And that could be for some kind of blood disease or hypercoagulable state or whatever. Not especially common. Embolic stroke is what's most common. Then there's the hemorrhagic stroke, which could be related to the aneurysm that ruptured or that hypertensive stroke that I showed you in the lenticular striates that at the basal ganglia. We'll call that a stroke, and it's a hemorrhagic stroke because the blood pressure was too high. It doesn't mean the blood vessel was occluded. It means that something blew up the blood vessel, either an aneurysm or hypertension. Blood pressure was 220 for 4 hours, and the patient just had a hemorrhage. So one thing that I think I should have taken out here was, okay, I'm sorry, I'm good. The thing about when there is a stroke in the brain, but there is no hemorrhage, CT in the very early phase can be normal. So you can have several hours of symptoms and have a normal head CT. The nice thing about MRI is that it's extremely sensitive for very early non-hemorrhagic stroke. I'll repeat. Hemorrhage in the brain, CT is always better. It can be seen on MR, but it's always more obvious with CT. A non-hemorrhagic stroke, MR is almost always better earlier than CT. That you'll find the stroke earlier, the territory earlier. So what happens on CT is that let's just take the situation where the blood vessel is occluded by some clot that flew off the carotid artery. And now the brain distal to that area is not getting enough blood or any blood. And the brain is starting to die. Although after 4 to 6 hours, which scan may be perfectly normal, now the brain distal to that abnormal portion of the brain starts to get less dense. It starts to get darker on CT. And depending on where it is, I can tell you what vascular territory it is. If it's in the frontal lobes, it's going to be the anterior cerebral artery. If it's the occipital lobe, it's going to be the posterior cerebral artery. If it's a particular portion of the occipital lobe, it's going to be a specific branch of the posterior cerebral artery. So just like any tissue that gets insulted, when the brain gets insulted because it doesn't have enough blood flow, it's going to swell up, and the cells are going to start to die. And it's that swelling of the brain that will also help you. What's happening is water essentially is rushing into that area of the brain. It becomes less dense. It becomes swollen. It starts pushing things away. And so that's another reason why you're going to see it. The important thing about CT scans in stroke, it may or may not be important to know exactly where the stroke is early on. What is important is to know if there's hemorrhage associated with the stroke. That's why CT scans are done all the time for a rule-out stroke. Look, I could walk into the ER. I could be taken to the ER with a complete hemiplegia, acute hemiplegia. You don't have to be a genius to know I just had a big stroke. But if you want to treat it and maybe save my life, you want to know if I am bleeding in addition to having the stroke. Because what we do now is we give thrombolytics, something to break up the clot that just flew into my middle cerebral artery and it occluded my entire right side, which is why I have left-sided hemiplegia. So the scan is done. They say, no blood. Okay, we can give him TPA, or we can do an intra-arterial thrombolysis where you go to the cath lab and stick a catheter into my brain and find the clot and lyse it. But if we go in there and they say, he's got hemorrhage there, if you give me thrombolytics, I'm going to bleed more. If you try to put a catheter in there and give me thrombolytics through the catheter, it's just going to hemorrhage more. It's going to kill me. So that's why knowing whether or not there's hemorrhage associated with the stroke is so important. That's why it's important to tell the difference between a hemorrhagic and non-hemorrhagic stroke. Okay, so here's a guy who was, moving right along and had some dysarthria. He had difficulty speaking, and he had some facial droop, and he had a right foot drop. I just made that shit up. But based on where the lesion is, I know that that's what he's going to have. So here's the normal brain. Here's normal brain. These ventricles are normal for the patient's age. If I told you the patient was 70, that's normal ventricles for a 70-year-old. If I told you the patient was 20, I'd say, I don't know why they're so big, but that's normal for 70. But here's this area here, which is definitely lower density than here. And so this is where the stroke is. This is where the blood clot is somewhere in there, blocking blood getting to that portion of the brain. Certain.
Is the water that goes in, is that like a compensatory mechanism?
Yeah, what happens, well, I mean, in a nutshell, you deprive that portion of the brain with oxygen. The ATP pumps quit, all that stuff stops, right? All that pumping of sodium and stuff, I forgot all of that shit, by the way. But all that stops, and what happens is all the blood, basically edema occurs, okay? So the water just starts to rush in there because it's not being, there's no homeostasis anymore. Sir.
Can you say that this is an old stroke? Like not
It's,
the past
well,
3 hours or
I can
something?
tell you that it's probably, this patient will say he's had symptoms for 6 to 12 hours. He won't say that it just happened 10 minutes ago, okay? So yeah, 3 hours into his ictus, into his symptoms, that's gonna be normal. Now, the larger the territory, the earlier you're gonna see it. And there are a number of other things on this scan that tell me that this is a stroke. There's notice again here, you've got these black lines, notice how they're gone here. All that edema is basically swelling up that portion of the brain. Now, this is a bigger territory. The whole right middle cerebral artery is completely occluded here. And so all this brain that's black is done. Now it's swollen because notice how there's a shift, ventricles being pushed over. So this is incompatible with human life. Okay, this guy didn't make it. And if this were to come into the ER, they would probably never treat this. It's too big to try to do the thrombolysis. The larger the territory, the higher the risk of causing a hemorrhage when you try thrombolysis. You want to do it when they're small, like that one. That one you could try. This one, you'd kill the guy if you tried to do thrombolysis.
So this
I mean, you guys already did.
All that shift is from just swelling of tissue.
All of this shift is swelling from this stroke, right? Which is probably now 12 hours old, maybe more.
This is an ischemic stroke. There's no.
This is an ischemic stroke. And there's no hemorrhage there.
Right.
No hemorrhage. We're all clear, right? This one, while there is no hemorrhage, it's probably too big a territory to actually go ahead and try to treat.
So we're just looking at the edema then?
You're looking at the edema you're looking at the edema and the swelling of the brain. Because the parenchyma itself is slowly just dissolving because it hasn't gotten blood in 12 hours. If there was blood, it would be white. Correct. Right.
Yes.
Yes, sir.
You said that you wouldn't use any thrombolytic medication because it would kill the patient, but isn't the patient in this case already gone?
Yeah, and actually, I mean, you can make a case for it, and I'm sure that neurologists deal with this all the time. You can make a case that, well, we should try. If this is 12 hours old and his whole right middle cerebral artery territory is shot, this patient is never going to recover significant function of any kind. I mean, this is where the neurologist has to earn his money and say to the family, it's over. There's nothing to do. There's nothing to save. So, I mean, it's hard work. Okay, let's talk a little bit about MR, and some of these pictures will be prettier. We don't have to go into why or how. Yes, sir.
I have a question about the stroke. Why, if they do like a biplane procedure, say for after
Do a what?
angiography,
Right.
after like 12 hours, even if you did get the clot out of there, like would the brain tissue even come back?
Generally speaking, at the 12-hour mark, nobody is a candidate. The people that are candidates for the thrombolytic therapy or for intraarterial thrombolysis, there's a window. It's generally 4 hours. Okay? If you can get to somebody in 4 hours, and they do this in Naples, they do it in Fort Myers. If you can get to somebody in 4 hours and either use IV TPA or intraarterial thrombolysis, you can dissolve that clot and you can largely or completely restore function in people. But it's going to depend on, like anything in neuroanatomy, it's going to depend on geography, where in the brain. 12 hours, nobody would ever do it.
Well, I just know, like, wasn't there a larger time frame in order, like, for the biplane? Wasn't it like, I thought it was like 6 or 12?
Well, intraarterial thrombolysis may be a little longer than IV TPA because you can be very direct as to what you're doing. Like you could try to lyse it with, instead of, when you give IV drug, you're basically you're anticoagulating the entire body, right? But if you have a catheter right next to the clot, you might be able to pulse spray that thing and get it opened up. So there may be a somewhat wider window. 12 is outside of any window that I've ever heard of, though. And again, the size of the defect is as important as how long it's been, because the bigger the defect, the larger the chances that you're going to cause a stroke by doing it. So MRI, radio frequency waves of non-ionizing energy interact with a magnetic field that is 1,000 times stronger than the magnetic field of the Earth. And somehow they figured out how to get signal out of this interplay and create images. We don't even have to talk anymore about how. But the nice thing about MRI is you can create images in any plane at all. So it can be axial, coronal, sagittal, kind of off axial, like weirdness, right? Which doesn't even have a name. And that's great because you don't have to reposition the patient. The patient can just be laying flat in the magnet and you can image in any plane you want. You can create very thin images, you can create thick images, you can create 3D images, you can do all kinds of stuff. It's very cool. MRI is great for soft tissue structures. It's not so good for bone. It's not so good for acute hemorrhage, okay? But as I said, there is an intravenous contrast agent for MRI, and it's called gadolinium, and it's a inert metal that's in a solution, and that when it gets injected, it causes some funky shifts in the magnetic field and allows the images to look different. I don't want to get too into it, but the one thing I want you to know about the gadolinium, first of all, I want you to know that gadolinium is an MR contrast agent. Iodine is a CT contrast agent. I want you to know that. And I want you to know that iodine and gadolinium can both cause kidney problems. Okay, iodine contrast agents can cause kidney failure. Gadolinium contrast agents can cause a more systemic problem that involves the kidneys called nephrogenic systemic fibrosis. I'd like you to know that. And so, just like anything else, you want to be cautious with what you give and when.
Is the creatinine cutoff different for both of those?
Actually, we don't measure creatinine for the gadolinium. We measure glomerular filtration rate. If your GFR is below 30, we don't give it. If it's above 30, it's okay. Okay, so here's an MR picture. If you were to look at that, you would say that's a CT, right? How can that not be a CT? It's not a CT. It's an MR. It's a T1 weighted MR image. I'll tell you it's a T1 weighted MR image. I don't want to try to explain what T1 means, but on T1, fat is bright. Fat is bright. Soft tissue, brain parenchyma is gray. Bone is black. So I know that there's a lot of fat around the orbits, around the globes inside the orbits. And notice how white that is. I know there's a lot of fat in the scalp. outside the skull. So that's where that's white. But I also know that on T1 weighted images, water is dark, it's black. Okay. Just like on a CT, where water is black. On a T1 weighted MR, water is black. Here's a higher up image, T1 weighted MR brain, lateral ventricles that have water in it, black. Brain parenchyma, skull and bone, black. Fat in the scalp, black. I'm sorry, white. White. T2 weighted brain image, T1, T2. You don't have to know. I don't even know that I'm even going to bother trying to. I'm not going to pimp you on the difference between T1 and T2. I promise. Okay. I have to remind myself, but I'm not going to do it. But on T2, water is white and fat is gray-ish, grayer than on T1. But this is really important for us. Water is white on T2. Higher image, just like that other one. CSF in the ventricles, white. CSF in the subarachnoid space, white. Skull, black, fat, gray. Now, I would much rather look at these all day than those CT scans or something like that because they're so pretty. But here's just some anatomy for you. Here's that corpus callosum that you've probably heard about. There's an optic nerve, optic chiasm and optic nerve, sella turcica with the pituitary sitting in it. There's the pons and the fourth ventricle and the spinal cord and medulla. Coronal view, looking face on. Now this one, just to confuse you, which I'm not going to do on an exam, but this is a T1 weighted image with contrast with the gadolinium. And gadolinium is pretty much, when we use gadolinium, we want to use T1 weighted imaging. It's not important why. But all these meninges now are lighting up. The lining of the brain lights up nicely, all the blood vessels. The internal cerebral veins light up. Here's the part of the middle cerebral artery. So the contrast material, the gadolinium, lights up the blood vessels, lights up the very vascular tissues. Well, you would say, well, the brain is very vascular. Why doesn't the whole brain light up? Well, there's something called the blood-brain barrier. Gadolinium doesn't cross the blood-brain barrier, but gadolinium will. The meninges are on this side of the blood-brain barrier, not on the other side. But the brain parenchyma is on the other side of the blood-brain barrier, and so gadolinium doesn't go across that. If you see brain tissue enhancing, that means there's a pathological process that has disrupted the blood-brain barrier, like an abscess or a tumor. So that's why we use gadolinium. Okay, here's an MRI, T1 weighted, and I would tell you that the patient had a visual field defect. He had a bitemporal hemianopsia. I know that exists, but I don't know quite what it is. But notice how there's this ribbon of hyper intense stuff right here in the occipital lobe. That's visual cortex, by the way. And that's going to be an early stroke on a T1 weighted imaging. Why is it bright, you say? You told me water was black. And if that's edema or swelling, isn't that water? And why isn't that black? Well, early hemorrhage on MR, when it does appear in the parenchyma, is white. You don't have to remember it. I'm not going to ask you. But that's why on the T1 weighted image, that's white. But that's not really where you're going to see those strokes. Here's that T2 weighted image where the water is white. Here's the CSF around the interpeduncular cistern. Here's the CSF in the subarachnoid space. Same patient. Now there's this white glob. That's the stroke. That's the non-hemorrhagic embolic stroke. Okay? That's not blood. This is an MRI, and the blood is not going to look like that on that sequence, but that's edema in the brain. The most sensitive, here's something I do want you to know about the most sensitive MR sequence for acute stroke. And it's something called diffusion weighted MRI. let's just say that what we're looking for here is where does water freely distribute, and where is it being restricted for some reason? The flow. I'll let you think about it as the flow of water. It's not really quite the same thing, but in normal CSF, like the normal ventricle, water molecules can basically do anything they want. They can go anywhere they want. Nobody's stopping them. And those are not restricted. But where there is certain kinds of disease states like stroke, water molecules are restricted. They can't do what they want to do. And this particular sequence looks for the areas where the water molecules are restricted. It's called diffusion weighted, and then these things just light up like a light bulb, like this. It's just absolutely, you can't miss it. Even when it's small, it's like obvious. There's an obvious area of restricted diffusion. And so that's where the same patient that I just showed you, that's where the stroke is. So we love this sequence to find early small strokes. And this is very sensitive and very early. And within an hour, somebody's going to have an abnormality like that. Sir? No, this is diffusion weighted. Yeah, it's his own thing. If you ever saw a list of all of the MR sequences that have been developed since the earliest days of MRI, which I remember, by the way, 1984, 85, 86, there are hundreds, literally hundreds and hundreds and hundreds of MR sequences that are specific to a specific thing. It's impossible to keep up with. Anyway, restricted diffusion. So diffusion weighted imaging, most sensitive for early stroke on MR. Remember that?
Is this hemorrhagic or not?
Not hemorrhagic. All right. I'm afraid I gotta speak up now because that's gone. Not hemorrhagic. All right, we're gonna kind of tear through the rest of this a little bit since I don't want you guys to be too late. We want to consider those kinds of modalities that are best suited to look at the blood vessels themselves. We talked about what happens when the blood vessels get occluded. Now let's talk about the blood vessels themselves. How can I see the blood vessels themselves? So there's two ways to do that. One way is to actually put a catheter in the blood vessel and inject it with an iodine-based contrast material and take pictures of it. And the other way is to either inject contrast in the vein to identify the arteries, or to use a set of sequences in MRI that show me the arteries without injecting anything. And that's called MRA, magnetic resonance angiography. Or I could use CTA, where I inject iodine contrast into the vein and look at the blood vessels. Or I can do conventional angiography, where I put a catheter directly in the artery or vein and inject contrast. Well, as you can imagine, conventional angiography is invasive and expensive and dangerous relative to the other ones, so we don't do that nearly as much as we used to. So we want to see if the blood vessels are narrowed, if there's atherosclerosis, if they're ulcerated, if they have abnormal connections to other blood vessels, if there's aneurysms, if there's blood clots. And what we often look at, especially, is the blood vessels feeding the brain, the carotid arteries in the neck, carotids and the vertebral arteries. Thanks. So to do a conventional or contrast cerebral angiogram, you put a catheter into the femoral artery, you put it up into the arteries of the neck, or then the brain itself. You directly inject the contrast into the artery. You take rapid sequences of X-ray pictures as the contrast floats out into the periphery. So here is a conventional angiogram. The catheter is probably sitting down here somewhere. Inject the iodine. Now, here the iodine looks black, but that's only because we just reversed the polarity of the picture, okay? It could look white or black. I could make it look any way I wanted to. So here is the bulb and the internal carotid artery. Here's the external carotid artery. How do I know it's the external? Well, that's the one that has all the branches coming off of it, because the internal doesn't have any branches until it gets up into the brain, okay? And you can see that this is wide open. nice, wide. Here's a conventional arteriogram of the intracranial circulation. Here's that internal carotid artery, just showed you here. Here it is. Internal carotid artery goes up there, and now here it comes through the skull base, and then it divides into the anterior cerebral artery and the middle cerebral artery. Notice how there's this big blob sticking off the middle cerebral artery. That's a big aneurysm. Okay, that is definitely something that gets clipped. So a neurosurgeon goes in there with a clip, puts a clip at the base, thromboses this, patient lives happily ever after. Now this is an MR angiogram. No contrast was given at all. None. No catheter in the vein, no catheter in the artery. They may or may not, you can do these with gadolinium or without, but you can make them really pretty like this even without. It's just the physics of the flowing blood and the magnetic field and the electromagnetic blah, 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 blah. Boom, you get a picture. I mean, it's like magic. There's a reason why the guy who invented this machine won the Nobel Prize. Okay, there is a very good reason. So these guys are pretty smart. Now here's a MR angiogram. Notice how on this one, okay, the blood vessels are white. Here the blood vessels are white. And now you've got this aneurysm sticking off here. You know, I may not get too crazy about the spine, but let me just see. Okay, so do you really want to get crazy about the spine? Do we want to get crazy about the spine? I do want to talk about C1 and C2.
Okay.
Because it's like two of the coolest bones in the body, C1 and C2. This is, you know, this is C1. The skull sits on C1. That's the atlanto-occipital joint, right? And then C2 kind of fits into C1, and that's the atlanto-axial joint. And this is the joint that lets your head go like that, right? This happens to be the area where the highest degree of cervical spine congenital anomalies is at C1, C2. It's also a place where you don't want to miss any fractures because there's some serious anatomy traversing here, right? The proximal spinal cord, very, very important real estate. And that we like to look at the open mouth odontoid or the atlantoaxial view so that you've got the dens, which is the tooth, the dens of C2, between the lateral masses of C1, and here's the lateral masses of C2. So this is the atlantoaxial joint that's pivoting on the dens, and very difficult to see fractures on X-ray. It's very difficult to get a good open mouth odontoid view like that one. Almost always now, people with suspected cervical spine injury go to CT. And there's a whole science about CT, about cervical spine fractures, and it's very interesting. It's one of the things that as a radiology resident, you have to just be able to live and breathe because there are a lot of subtle cervical spine fractures that you don't want to miss. You don't want to miss any of them, but the mechanism of injury is very interesting. If you ever have an interest in cervical spine trauma, it's so interesting the way the cervical spine works and the way it breaks. And I'll just leave it at that. We can create these images so that you can oblique the patient or oblique the tube, it depends, whatever you want to do, so that you can see the nerve where the neural foramen are, so that where the nerve roots are coming out. You want to be able to see how wide those are. If the patient has degenerative disease, that there's pinched nerves in the cervical spine. It's right here when there's degenerative disease and that hole gets really small and the nerve is trying to get through it. It's it can be very painful. Here's the thing that I do want you to know about the lateral cervical spine, especially in an ER setting. Patient comes in on a backboard, and your doc is going to say, let's get a lateral cervical spine to clear the C-spine. And you do that, and you look at the computer for the report, and I said, cervical spine cannot be cleared because I can't see C7. And every radiologist is going to say whether or not he can see the entire cervical spine. And if he can't see the entire cervical spine, then I'm going to explicitly tell you, I can't see all of it, and you better get a CT. So the way to count is on the lateral, this is going to be 2, that's the DENS. So the body of C1. We're almost done. Body of C1 is that, this lip right here. 2, 3, 4, 5, 6, 7. I can see all of 7. I'm good. That's a perfect lateral C-spine. But these patients come in on a backboard and they can't move or they're in pain. You might see it here. And I'm not going to tell you that cervical spine is cleared. And that's why we do fewer and fewer lateral C-spines in the ER. It used to be ubiquitous everywhere. Now people just go to get a head CT and a C-spine CT. I can tell you all you want to know about the C-spine on the CT scan.
Oh.
Okay, that is not normal. Patient probably has ankylosing spondylitis. How do I know that? Because this margin is just all bone. All bone. The disc doesn't come out to here. It's just fused bone, and it's just like a stick. You take those ankylosing spondylitis patients and give them significant cervical spine trauma. That's what happens. There's no. I'm sorry. Go ahead.
No living patient.
Not anymore. It's not compatible with life.
What do you call that?
You would call that dissociation of the head from the rest of the body. But the patient probably has ankylosing spondylitis, which is it's actually an autoimmune disease where the spine basically just fuses. These patients just, it's a terrible thing to walk around. It's terrible. Not a good disease. So on a C-spine, CT, you can obviously see this is an axial image. Here's the spinous process. These are the vertebral foramina where the vertebral arteries come up through, right? This is where the spinal cord lives and the meninges. And we don't need to go too crazy with that. But I can take those axial images of the cervical spine and if I cut them thin enough, and then tell the computer to create me a sagittal view, create me a coronal view, I get this. And every C-spine I ever read, I read the axial source images, and then the recreated coronal and sagittal. And this is actually, these are the most important images of all of these sagittals. Because if you page through it, side to side, you build a 3D model of the cervical spine in the brain. This is what radiologists do. I don't expect non-radiologists to do that because we do this all the time. And then you basically build a 3D image of the cervical spine. You can see where all the nerves are coming out. You can see where all the subtle fractures, etc. So if you put contrast material directly into the spine itself, the CSF that surrounds the nerves, that's something called a myelogram. We've done that for those things for years and years and years. But now, as far as myelography is concerned, we can actually do that without putting a needle anywhere. We can use MRI to do that. So a conventional myelogram requires a needle in the spine. I don't know if any of you have ever had one or seen one done. They're kind of fun to do. I would rather have it not done to me. But what happens is you put the needle in, you inject a little iodine into that CSF space, and then you take some X-rays. And you basically outline all the nerve roots. You can see the gray wisps are the nerve roots themselves. And these are very nice. And then you can see where the discs might be bulged or herniated or something like that. You can take that patient and put them in a CT scan. And then the white here is going to be the iodine that is injected around the spinal cord. As you can see, the nerve roots, etc. But now we do this with MRI. That's going to be a T1 weighted MRI image of the cervical spine. This is a T2 weighted image of the cervical spine. There's no contrast injected here. This is just the natural CSF. That just is white, and it just very nicely shows you where all the nerve roots are. So we don't see on this one. CSF is white, all the little dots are the nerve roots. I mean, it's a nice way to, it's much easier, and it's much easier for the patient. It's much easier for us. You can see where the discs get herniated. Here's a big herniated disc at L5, that's one. That's kind of compressing the cord, the nerve roots a little bit, and compressing the spinal canal.